What up, Light Fighters and fellow nerds? This is Light Fighters Anonymous. Thank you for tuning in. Are you getting suspicious of your team medic like me because he says he's pulling his weight, but you don't think that his little boo-boo bag weighs nearly as much as the 240 ammo that you got to carry in a rucksack? Well, I think you are right. Are you sick of your fucking team medic only handing out foot powder and ibuprofen every time you got problems? Are you sick and tired of them making up big fancy words like balanced isotonic crystalloids and pericardial synthesis and thoracic cavity just to fucking sound smart? We all know those are made up. Are you sick of their arrogant use of the metric system? Why won't they share the lollipops? What the fuck is a milliliter? Are you scared of needles too? Oh, I can't give you the lollipop, so I'll lose my job. We've got an airtight plan to drown a raccoon and say that he got into him. I got this shit at home. Well, we at Light Fighters Anonymous are fucking sick of them too, and that is why I became a paramedic, just to prove how easy it is.
Learn to dance like that sarcastically?
Yeah, I guess. Stay out of my personal life, okay? The kid flies private.
There's a man with a gun over there, telling me I got to beware. I think it's time we stop. Children, what's that sound? Everybody look what's going down.
All right, so bear with me here. As a light fighter paramedic or a field paramedic, combat medic, whatever you want to call it, you're actually in kind of a very special and privileged position here. Now bear with me. Your entire patient population consists mostly of young, healthy, fighting-aged males, and their major problems are going to be traumatic injuries ranging from small to very catastrophic and severe. But hang with me, this is actually a good thing, because as a civilian paramedic, my patient population is primarily piss-soaked homeless people and your Mima who wants you to call her and give her a talk to because she misses you. And my general problem in the field is like human feces in places where human feces does not belong. So I think combat medicine and trauma care is actually way easier. So when I weigh up those two options of other people's gunshot wounds versus other people's feces, I choose other people's gunshot wounds 10 out of 10 times on the big scoreboard of life. Now, that is good. And I'm saying this is all a good thing because you've got a young, healthy, fit population, and you can actually rule out most of what real paramedic school actually is. Real paramedic school is way too long and way too hard for no damn good reason, because it consists of things like cardiology, which is like the study of electricity across the heart, which is dumb. Things like pediatrics, which are just small adults and you can treat them as such. Things like OB, which is vagina stuff, scary. And things like pharmacology and pharmacokinetics, which are the study of drugs, not the cool kind, and how drugs move through your body. So how you can affect, keep people alive with medicine and drug therapy. But as a field medic, you can take that big bundle of shit and then you can pile it up with a bunch of the other shit that are slave labor hours, that are called clinicals, and you can just throw them right out. And I am betting you could probably get all the knowledge you need to be a pretty goddamn good field medic in the time it takes you to watch this video right here. So stay tuned, and we're going to talk over some shit that will make you just as good of a field medic as me. Why not? I don't know. This is probably a great time for a disclaimer. I'm lying. This is a joke. Don't take this as any medical information or knowledge. Don't sue me. Don't go practicing medicine without real training. Real training. We know they're onto something. Their real training is just mid-level LARPing and reading books. So like I said, I'm going to try and make a series for the first time ever, and we're going to go over some of the myths, dispel some myths, and go over and try to demystify some of the process of field medicine and really get down to the nitty-gritty. What do you actually need to know? People are always saying, hey, you need to go get some good medical training, because they got to cover their ass. But I'm gonna tell you some pretty good, solid medical training, and we're gonna try to condense it down and make it fun, and we'll go in like a short series. And I don't know what these parts are gonna be at, but probably today I'm gonna talk about assessment, because it's a critical portion, and finding out what's wrong with your patient. We're definitely gonna go into IFACs next time. We'll rip apart an IFAC, talk about the good, the bad, and the ugly. We can get into some stuff like triage and probably patient transport. Those are very huge things, and I imagine they're very critical as a combat medic when you're dealing with mass casualty producing weapons and events that can be catastrophic like such. So hopefully we make this into a series, but today we are going to talk about the assessment process. And that is basically what makes a good paramedic is a good assessment, a good assessor. And so all an assessment really is meeting your patient and finding out what's wrong. You're going to try and fix the things that are fixable, understand what's not fixable, try to stop things from getting worse, and then you're going to start working your way to the hospital, because we as medics are not doctors. We are not surgeons. We do not have a vascular surgeon on call. We do not have a blood bank nearby. So these are all life-saving things that you need to save combat injured persons. So what we are is just trying to keep things copacetic in the meantime. So your assessment begins at dispatch is the answer to your test question, by the way, if anybody's going to go take the test. But your assessment begins basically as you approach your patient, you see your patient, and you make eye contact with them. If they're able to make eye contact with you and track your movement through the room and address you, say hello, hey, I'm hurt right here, that's perfect. You know they're conscious. If they're able to speak to you, you know their airway's clear. If they're speaking multiple word sentences, you know they're breathing probably appropriately, and then you can see their skin color and condition, and you can assess their circulation, all from 10 to 15 feet away from your patient. Now this is called your rapid or your initial assessment. A lot of people call them a different thing, all right? But it's all basically the same thing. And this boils down to one of your first of your three assessments. So your three assessments that I would argue are your initial or your rapid assessment, and then you have your primary, and then you have your secondary. Now you kind of always generally going to get through an initial assessment, kind of a size up as you walk up to your patient, and you're going to start a primary assessment. But just because we have a secondary assessment doesn't mean we're always going to get to it. We might get stuck up on our primary because as we see problems, we're going to be fixing problems, okay? So our three assessments, and they begin with the initial or the rapid. And that's when we walk up to our patient, we initially assess them. Hey sir, how you doing? If they can look up to us and talk to us, perfect. We're able to assess a lot of things just from that. If they don't look up to us, we got to say, okay, is this person unresponsive, or are they distracted by their injury and they're just not going to respond? So then we can begin assessing levels of awareness and assessing critical problems and working our algorithms. And that's what all these big bad classes are going to teach you. Paramedic school is death by algorithm, death by mnemonic, and I promise you as a good paramedic that if you are ever having to think about a mnemonic when you're treating your patient, or have to think about an algorithm while you're treating your patient, you're already behind the 8 ball, and that sucks for some people that really need these devices. But that is the truth of the matter. Good paramedics don't sit there on scene and go like OPQRST to find out, to assess pain, or they know the questions to ask, and they have leading questions that get them to better questions to diagnose and make differential diagnoses and such, blah, blah, blah. Getting into the weeds. 3 assessments. First assessment's that initial assessment. Find out if they're conscious and if they're answering us. Then we go into the primary assessment. This is going to be your algorithmic assessment, if you will. The military uses MARCH, M-A-R-C-H, and M stands for massive hemorrhage, and then it goes to A for airway and down to normal stuff. PHTLS, which is pre-hospital trauma life support, which is the standard trauma class for civilian side pre-hospital care. They teach X, A, B, C, D, E. I don't even fucking know what the D and E stand for. I'm sorry, I've had this class like 15 times. I can't remember, it's not important to me. And the X stands for exsanguation, it's bleeding out. Big bleeds is what it really is. And it starts with an E, I'm pretty sure. I don't even know why they spell it wrong with an X. Try to get it stuck in my head, and it is. Thanks a lot, assholes. But it stands for big bleeds. So basically, as you're going through your primary assessment, you're looking for things that are repairable or things that are going to become irreparable, and that's like massive blood loss, okay? That will kill our patient pretty quickly, and the problem is if they continue bleeding while we're addressing other issues, that bleeding can become irreparable very quickly. So the first step of working your algorithm on a trauma patient always starts with finding big bleeds. Now, I'm not going to tell you how to touch your patient and pat them around and find big bleeds, but you find the bleed, you stop the bleed. If it's a big one, you find it and stop it, all right? And that's pretty simple. Tourniqueting limbs. Find a video that teaches you how to do that. Pack junctional areas and your hips. Don't pack the chest cavity or the abdomen. Don't pack the neck. Don't pack the head, you psychopaths. And then you seal the box with chest seals or anything sticky and solid, or just tape an MRE bag or anything that's going to be occlusive and not let air or blood in and out, okay? Once we've occluded the box, we're allowed to make more holes in it with chest darts. These are small controllable holes that we make, that we choose the location of, and we have access to them when we want. So seal the bad holes, make new holes if you need them, and rock and roll. That's pretty much finding a problem, fixing a problem, and stopping the bleed as you come to it. So we have just started our primary assessment, and we're at our very first step, which is bleed stoppage, okay? Which is an X sanguation, XABC, or M, massive hemorrhage if you're using your March algorithm, or just doing the right thing if you're a good, competent paramedic and you know what to fix first. You fix your massive bleeds, and then you've got to go to your normal stuff, your ABC, which you've heard a lot, just airway, breathing, circulation. Start with your airway. A closed airway, completely obstructed, you can't breathe air through. You've got about 3 minutes because you're not getting oxygen into the lungs, okay? So that's got to be cleared and fixed very quickly. Lots of different ways to do this. We'll get into those in another video. Breathing. Is your patient able to ventilate himself and move air by himself, which is, assessed with chest rise and fall. You can also auscultate the lungs, which is just a fancy word for listening that they try to confuse you with, but it's just listening to the lung sounds, seeing if you can hear air moving in and out of their lungs. So breathing, make sure they're breathing adequately. Breathing is either classified as two things. If you ask a good medic, it is either adequate or is it inadequate. After there, it can go different places, but it's either adequate or inadequate first. So see if they're breathing adequately. And then finally, assessing circulation. That's finding pulses on their body, but pulses aren't always the most important thing. It's very important, but also the most important thing, the most telling thing for you is going to be skin color and condition, and just the overall presentation of your patient. If they're looking shocky and pale and they have altered level of consciousness, you're in trouble. So that's assessing circulation, and you need to be treating for shock at that point. So your primary assessment is simply treating your big problems that are your life threats, your major bleeds, your airway, your breathing problems, your major circulation problems, and treating for shock. Everyone dies from shock. Everyone dies from shock. Don't argue with me about that. Everyone dies from shock. And then finally, once you've completed your primary, if you're able to complete your primary in the time it's taking you to transport your patient, because remember, we're initiating rapid transport right away because we are not magicians and we are not vascular surgeons. We are paramedics, and we're keeping it copacetic in the meantime between the injury and the vascular surgeons and the magicians in the hospital. But then, as we're rapidly transporting our trauma patients, if we get through our primary assessment, we can then begin our secondary assessment. Now, the secondary assessment is really kind of people will call it the head to toe or a detailed assessment. This is when you're going to start looking for additional injuries. Start at the head, work your way down. You're going to ask a detailed history from your patient. They use the mnemonic sample, SIM, PLE, which is just a mnemonic to get historical questions about medicines, allergies, blah, blah, blah. You can use OPQRST, which is another mnemonic to assess pain, find out if it's radiating anywhere, find out if they have any additional pain that you haven't yet assessed. And then you want to go down head to toe, every little detail, make sure there's no additional injuries, make sure there's nothing that hasn't been found yet, and assess everything. After you get through with that, depending on time and how much transport time you have, you're going to be doing reassessments, and first always reassess your ABCs, and then reassess the interventions that you've already done. Reassess your interventions, make sure there's no additional bleeding where we thought we've stopped it, make sure he's breathing where we think we're breathing for him, or the airway's still in place, and then go through a quick detailed assessment again. In your secondary assessment is when you get your vital signs, your first full set of vitals, okay? So a lot of paramedics, especially on the civilian side, the first thing they do is they slap that monitor on them because it's so damn easy. And I don't blame them because I do it too. Slap the monitor on, get the vitals going while you're talking to them. Because literally as you walk up and talk to the patient, I've already done that initial assessment. And I've also seen that the initial assessment tells me they're talking to me, so their airway's clear, they're breathing appropriately. Now I can just look at them, assess their circulation as I'm talking to them. Also, I'm getting a blood pressure, so I'm getting a number on it and a pulse. This is all bonus. And then we already know that they've got no real life threats. So your initial assessment is a lot of it, guys, because hopefully most of the time your patients don't have any life threats. But if they're unresponsive and they're unable to talk to you, you got to approach them and you just got to start working your algorithms or working your primary assessment. Find a problem, fix a problem. I hope that was fun. I hope that was informative and entertaining. Remember, don't go practice medicine without a license. In the future here, in a couple more videos later, we're going to be going through my major medical bags. I've got a major medical trauma. I've got a major medical, like, call a sick call or portable pharmacy right here. And then we're also going to be digging through, we'll rip apart some IFAKs, talk about the good, the bad, and the ugly of what's in an IFAK next video. What do I carry? What do I not carry? A couple different styles here, not important. And then finally, some of the most important stuff is your extrication or your movement equipment, how you're gonna get your patient off the X and transported to the magicians at the hospital. I've got a couple different examples of tarps, talon stretchers, and skeds here. So we're gonna go through some use of those. Moving your patients is one of the hardest things you'll do as a paramedic. So it is very important that you're able to move yourself, stay fit, stay in shape, and stay smart, and then practice your skills. So I hope you're able to stay with me for the next couple videos in this series. Who fucking knows? I don't know. And I hope you guys had fun. So stay sharp, rock on, like and subscribe. It helps a lot, and you guys are the reason I'm doing all this.